Welcome back to Therapeutics. In this block, we're going to review the antivirals and the antiretrovirals. In this presentation, like we do in a few other presentations, we often will provide a lot of detailed content in some areas or some practice areas. And that's true also in this block, particularly as it relates to some of the lesser used agents for HIV, and then also some of the practice guidelines that are not as critical for someone who's primarily in primary care to be aware of. But we do want you to have at least a little familiarity with that these guidelines are available, or that the slide with this level of detail illustrates a larger picture. So our intent is for you to sort of, when you see those slides with the 747, have an appreciation for the overall content of them, but don't worry too much about a lot of the detail that's embedded in those slides. So the objectives in this block are to review the agents we use for viral infections, starting off with the antivirals, particularly as it relates to herpes viruses and a couple of other specified conditions, and then switch into the antiretrovirals, which are the mainstay of HIV therapy and to some degree some of the other viral infections as well. So let's first start with the treatments for non-HIV infections. And keep in mind, when we're dealing with treating viruses and viral infections in patients, our goal usually is to suppress viral replication. It's not very often that we actually achieve clearance of the virus. We have seen that, however, thankfully, in the more recent regimens for hepatitis C, but we don't really see full eradication of the virus in many conditions, but we see enough suppression that the patient can continue to a normal level of health. So let's first look at the herpes virus infections. And these include herpes simplex, genital herpes, herpes zoster, and varicella. And we also talk about some of these in other areas in the curriculum. We often will talk about them again in sexually transmitted infections. We'll also talk about them in dermal infections, particularly as it relates to herpes zoster. So there's some overlap throughout curriculum with these concepts, but here they are sort of reviewed again. So as we think about the agents for herpes, the mainstay agents we use are the purine nucleoside analogs. These are DNA polymerase inhibitors, and the standard agent we think of is acyclovir. Acyclovir has been around for a couple of decades. It works quite well at suppressing herpes viruses, particularly when we start therapy initially at the first outbreak or indication that we have a herpes infection going on. And acyclovir has the advantage of being available in IV form as well as oral form. And for a herpes infection, for example, encephalitis in the CNS, we would actually use high-dose intravenous acyclovir, usually in that case a dose as high as 10 milligram per kilogram every 8 hours. All of these agents, the family of agents, both acyclovir but then also famciclovir and valacyclovir, they're largely, for most herpes infections, can be used interchangeably if the dose is adjusted appropriately. But we'll find that the advantages of famciclovir and valacyclovir are that they are effective a little bit longer, and so they allow for a greater viral suppression and allow for dosing at a every 8 or every 12-hour interval, where ideally, at least for active herpes infection, we often with acyclovir need to dose it as often as 5 times a day. So that's going to be an issue for us. For all of these agents, though, renal dosing adjustments required, but they're generally pretty well tolerated. Acyclovir is a first-choice therapy for herpes simplex virus and varicella virus infections, also for herpes encephalitis given intravenously. We will see, though, that the famciclovir and valacyclovir have a clear role, probably a preferential role, when you want to have viral suppression long term. And that's particularly true when we're treating genital herpes infections, both for suppression and for active outbreaks. And so in the case of genital herpes in particular, we often find patients will be often better served with a longer acting agent as opposed to using acyclovir. But these agents are only effective against a herpes family of viruses. They do suppress viral replication by affecting the synthesis of viral DNA. There is some degree of potential resistance as well, so that's something clinicians keep in mind, but we don't see a lot of resistance with acyclovir. At least I'll tell you in my practice area, I have not seen that that's a major speed bump to the use of acyclovir or valacyclovir or famciclovir. Adverse effects is generally well tolerated. The IV form, which is given at higher doses, is typically, although it's well tolerated, might cause some infusion reactions or phlebitis at the site of an injection. And for patients who are dehydrated, there is a potential that acyclovir in high doses could crystallize in the urine and cause a urinary obstruction or urinary or renal insufficiency or nephrotoxicity. Usually that's reversible, but is something we want to avoid. So with high dose acyclovir, we often will want to make sure the patient's reasonably hydrated. There are lots of different regimens. We'll use different regimens in dosing for acyclovir, valacyclovir, or famciclovir based on the indication. Higher doses for acute viral infections with herpes infection, and lower doses when we're looking at suppression or need to adjust for renal dysfunction. There's also, with acyclovir in particular, a formulation topically that's used for herpes simplex dermal infections. But again, if we have that happening, we want to make sure that we have therapy starting at the initial outbreak. And all the best that you can hope for with the dermal preparation is you may shorten the duration of the outbreak a day or two if you started early, and maybe cut back a bit on the severity of that outbreak as well. So it offers some benefit, but it's somewhat limited. Not very often in practice these days do we require treatment for cytomegalovirus, but this would usually be in a severely immunocompromised patient who has CMV, particularly retinitis in the eye. And that would be, for example, a risk for patients who are transplant patients on immunosuppression for transplant, or advanced HIV with a CD4 count very low. But even then, in this day and age, particularly in our management of HIV, we use aggressive antiviral, antiretroviral therapy with HIV, and we really find patients do quite well with those therapies, and so the CD4 counts don't get that low. So you should have at least a familiarity with the agents for treating CMV retinitis, and those include some IV forms, and the last is an oral form. Cidofovir, foscarnet, and ganciclovir are all given IV for severe CMV infections, particularly retinitis. And then the oral form, valganciclovir, can be continued usually after initial doses of oral ganciclovir. So we'll see this very sort of common in a practice in an ID service where you'll see severely immunocompromised patients. If that's not your practice area, it's likely you may never or rarely see these drugs used. All right, let's look at treatments for hepatitis B. And we've seen some advance in the management of Hep B over the last 4 or 5 years. So let's go through some of the national guidelines from the American Association for the Study of Liver Disease, and they put out some treatment recommendations for management of chronic Hep B. The approved treatments, and as a sort of a list of a table here, are using in what was an older regimen that is still a preferred regimen in some patients, is using pegylated interferon product. And this interferon basically works, augmenting natural cytokine activity as its antiviral mechanism. And generally fairly well tolerated in most patients. The big issue with the interferons is that they are considered contraindicated in patients with severe major depression or suicidal ideation, so we have to watch for that. We also have and Tecovir, which is guanosine nucleoside analog, which inhibits Hep B synthesis. And that's also a pretty standard therapy to use in active Hep B. And then we have two different formulations of tenofovir. Tenofovir are antiretroviral agents. They're nucleoside analog reverse transcriptase inhibitors, which are also used in Hep B and HIV. And these agents have a certain role also in Hep B. So we'll come back and talk about tenofovir a bit more when we talk about HIV. But they're generally well-tolerated agents. The next slide will go through a little more characterization of what we expect for each of these agents. So the pegylated interferon, interferon 2 alpha 2A, really binds to the human type 1 interferon receptor. The big issues with this, it's a sub-Q injection once a week. It's long-acting because it's pegylated. It's given for almost a year. And its major concern we worry about, and I think the biggest issue whenever you hear interferon therapy, is the risk for suicidal ideation and depression, severe depression. So folks who have a history of depression, a history of post-traumatic stress of any kind, or have any potential for suicidal ideation, we would not use an interferon product for them. And for everyone else who's on interferon, we need to monitor for that should that come about. And Tecovir, also an agent, could be used for Hep B, also considered a first-line agent, as are the two different formulations of tenofovir, which could be used as well. There are also some non-preferred second-line agents in Hep B, and we're not going to go into depth here. Lamivudine, adofovir, and telbinavudine are agents which, because they're not really first-line, I don't think it's critical for us to go into depth with them. But I'd encourage you that if your patient is on one of these therapies, become familiar with both the adverse effect profile of these agents, particularly the risk for lactic acidosis or pancreatitis or acute kidney injury, and that really it's those adverse effects that and their efficacy that has probably rendered these agents more second line. The American Association for the Study of Liver Diseases also outlined their efficacy for their first-line agents and their relatively effective at viral suppression. And the charts sort of list here, depending on what the hepatitis B status of that individual patient is. So you have at least familiarity with that. And finally, the next two slides for Hep B look at our management strategies for someone who is surface antigen positive, and what we then look at based on whether their liver function tests are within the upper range of normal or 2 times or more than 2 times above the upper range of normal. Also looking at their hepatitis B viral DNA load and assessing when we treat and when we don't treat. So you can look at this sort of graphic, which helps the hepatologist, who's really going to be the person managing Hep B, to sort of look at least what the latest recommendations and guidelines are on what we do or how we monitor or treat a patient with hepatitis B. And for a hepatitis B surface antigen positive versus who then converts to negative status, also the recommendations for treatment guidelines, also based on LFTs. Couple of the last couple of charts or tables here, and the last one from the American Association for the Study of Liver Diseases is the antiviral options in the management of antiviral resistance. So if you see resistance, then what are the roles for those second-line agents when the first-line agent hasn't worked, or vice versa? And so there's some guidelines here that the hepatologist who's involved in managing Hep B or the infectious disease service sort of may look to for guidance as far as how to manage that. A couple of tables also that may be helpful as a review of the hepatitis B serologies, the surface antigen status, core antigen status, and E antigen status, and then whether there are anti-surface antigen antibodies available or anti-core antibodies or anti-E antibodies. So all of these are sort of markers that help assess the status of the person who has hepatitis B. There are also sort of definitions of whether someone is in an inactive carrier state for hepatitis B versus if they've got chronic hepatitis B infection. And that's got to do with both serological markers, but also whether or not their liver function tests, particularly their AST or ALT, are elevated either intermittently or persistently. Finally, and probably one of the key issues that every primary care provider should be aware of, is the hepatitis B vaccination schedules, which is most of hepatitis B is preventable with appropriate vaccination. And in fact, with newborns in the United States, it's routine really within the first hour of life to start their hepatitis B vaccine. And Hep B vaccine is actually the first vaccine any infant would ever get. And they often get it before they leave the hospital if it's a hospital-based birth. So there are sort of guidelines. There are different products that are used. Some products are intended for infants or children, others for adults. You want to make sure you have the correct product correlated to what the indication is for. And then if you have or should have available to you on your mobile device, for example, the CDC's has a vaccine app that is superb, and it will help guide you through all of the vaccines based on age and comorbid status, which patients are candidates for which vaccines, and gives you most of the basic information you need about each of those vaccines. So I would really encourage you to do that, but virtually every patient who's at risk for hepatitis B, certainly those include anyone who works in healthcare and anyone else who works in a setting where Hep B is more problematic, as well as folks who have certain risk factor behaviors for hepatitis B. And in general, most patients are going to be candidates for a Hep B vaccine one way or another. The Center for Disease Control also posts and updates periodically post-exposure guidelines for folks who have not had hepatitis B vaccine but have had an exposure. That exposure could be, a bite or a blood-borne transmission of something like that for hepatitis B, or another transmission for hepatitis B. And so you want to look at what the role of pre-exposure testing is, and then who is a candidate for post-exposure prophylaxis. Typically, the most patients, what you'll see is that you will look at both the patient being vaccinated if they haven't been vaccinated or complete vaccinated status, and also give hepatitis B immune globulin. And Hep B immune globulin is sort of a standard approach when you can quantify what the hepatitis B exposure risk might have been. Let's now move on to hepatitis C. And I think one of the things that is really great news in infectious disease over the last 5 years or so is the availability of really very effective treatments for Hep C, which has really revolutionized the management of hepatitis C. So there are different treatment modalities that are effective for hepatitis C viral infections. There are NS5A inhibitors, the non-nuclear nucleotide NS5B inhibitors, and the protease inhibitors for the NS3. So they work in different points in the cycle of viral replication. And typically what you'll find is that the regimens that are used, typically in combination, usually will hit two different points so that there is less chance for resistance. If there's a potential for resistance for a Hep C viral particle with one of the agents, the other agent will sort of hopefully prevent replication. And the recommendations and the guidelines are often changing, but here is a table that lists the hepatitis C medications that are on the market. The two in the lower right-hand corner are actually agents that have been discontinued. But the four agents that are highlighted here, and we'll go through them in more depth, and we'll look at where they show up in the guidelines. The ones that are highlighted in the red box here are the four combination therapies that are the most common first-line therapies for most of the genotypes. And so that's where our focus really is going to be for this sort of this block. In practice, if you're managing Hep C, working usually with a hepatologist, you're going to be much more familiar with all of these agents. But you will see a fair number of patients on a regimen for one of these, and you need to be aware of things to think about when a patient's on one of these combination products. So one of the four is Zapatier, which is a combination of an NS5A inhibitor and an NS3/4A protease inhibitor. So really by using sort of two different mechanisms again, this combination is pretty well tolerated in fact, all of the four first-line agents are pretty well tolerated for most patients. The common side effects are usually headache, nausea, and fatigue. Another combination sort of product here with another protease inhibitor in combination with an NS5/4 is Mavriet, and that is also sort of widely used or pretty widely used or available as part of one of the protocols as well. The third one, probably the one that has most name recognition for clinicians, is Harvoni. And this is a NS5A and a 5B inhibitor, also pretty well tolerated, weakness, nausea, headache, fatigue being the major ones. And finally, Epclusa is a NS5A and B inhibitor combination as well, also pretty well tolerated. And so you'll see these regimens there. The nice thing about these agents, these combination therapies, is that they're fairly easy for patients because most of them require only a single daily dose, and it's all depend on the genotype and whether the patient has been treatment naive or not. So we'll go through some of the national guidelines regarding which agents are chosen and which and how clinicians pick which one. So with hepatitis C, typically what we're going to find is that we're going to look at the genotype, and then we're going to evaluate, depending on the genotype subtype, whether or not the patient is treatment naive or has had treatment and failed treatment of one way or shape or form, and whether or not they have cirrhosis existing or not. And so we're going to really focus on the particular first line as opposed to the alternative regimens. And those include the four regimens that we just really spoke about. But the type of drugs that we'll look at typically are regimens that are a daily fixed dose regimen of a single product, and the duration could be, depending on the particular regimen that's chosen, anywhere from 8 to 12 weeks. The data, generally good for these regimens, well tolerated, and the only downside to these hepatitis C regimens, particularly in the United States, is that they are extraordinarily expensive. And when they first came out, a course of therapy for 8 to 12 weeks was in the range of about $80,000. That pricing has come down. There's been a lot of concern among clinicians and patient advocates regarding the availability of affordable hepatitis C regimens. So that is in the process of being evolved, and hopefully we'll see more affordable hepatitis C regimens and insurance coverage to be widespread for it. But this can be a speed bump for a subset of patients. There's also similar regimens available, but often they're longer regimens for folks who have compensated cirrhosis, who are genotype type 1A. In these cases, all the regimens are 12-week regimens. Here are the national recommendations for the choices, either 8 or 12-week regimens for genotype 1B without cirrhosis, and there are a couple of 8-week regimens listed here. And then a 1B with compensated cirrhosis, all of these patients require the full 12 weeks of therapy and one of the approved regimens that's listed here. Here's the recommendations nationally as of early 2019 for the genotype type 2 without cirrhosis. There's really only two choices, Here, one of them being an 8-week regimen. Here is genotype recommendations for genotype 2 with compensated cirrhosis, and these are both 12-week regimens. But you can see by the genotype, the theme is that the genotype dictates which regimens have more efficacy in studies, so which ones are first-line therapy. And then you'll see that some of the shorter regimens are possible if a patient doesn't have cirrhosis, but usually for patients who have cirrhosis, they require a longer duration of therapy. For genotype type 3, there's an 8 or a 12-week regimen without cirrhosis. For genotype type 3, our regimens are longer duration because of the compensated cirrhosis. For genotype type 4, again, some 8 and 12-week regimens. And for genotype type 4 patients with compensated cirrhosis, all 12-week regimens. And finally, for treatment-naive patients in genotype 5 or 6, there are 8 or 12-week regimens depending on other factors, cirrhosis particularly. But then keep in mind that all of what I've listed here are for treatment-naive patients with these genotypes. If they've already been on certain treatments, there are other guidelines, and I encourage you to go to the national guidelines to sort of look at that and be familiar with that. But I think as clinicians, the big issues you'd want to be aware of is that recognize when a patient has Hep C, are they being followed by the appropriate clinician? Are they on one of these appropriate regimens? Are they adhering to that regimen? Are they tolerating it well? Are they completing the full duration of that regimen? And are there any potential interactions with the drugs you're using that affect that regimen? There aren't too many drug interactions that are major that we as clinicians see when we're using other drugs for these patients, but you do want to run that interaction check to make sure there's not a problem. One of the other common viral infections we worry about is influenza, particularly the prevention and treatment of influenza. And many patients will sort of poo-poo, oh, it's just the flu, and the flu is, I feel lousy, but flu's not going to kill me. Well, that's not true. In some flu years, influenza can be fatal. I mean, obviously, in American history, the season we think of most is 100 years ago in the winter of 1918 to 1919, nearing the end of the First World War. We saw major deaths, and who was affected most by influenza in that year were young, healthy adults. And so we would have patients would describe and families would describe that the patient was fine first thing in the morning, and by the end of the day, they were dead. That strain of influenza was rampant among patients and caused a lot of inflammation and was fatal to a great number of individuals. If you've ever had the opportunity to watch or a fan of American history, I know that public television about a decade ago in a program called The American Experience did an hour-long presentation on the influenza outbreak of 1918, 1919. And if you ever get the chance to watch that, I strongly encourage you to see that. It's pretty eye-opening about the severity of influenza, and it would motivate you, hopefully, and talk with patients to motivate them to do the appropriate influenza vaccination and treat influenza seriously. Even in, I know, and this is being the late influenza season when I'm recording this, of 2019, and it is currently beginning of April 2019, we've recently in our own state in New England have had a recent childhood death from influenza caused by influenza. And so keep in mind that influenza is still a fatal disease, and depending on the season, can be dramatic. That's going to be particularly true for patients who don't get vaccinated. So let's talk about the vaccination, how effective it is. Now, the influenza itself has, as we alluded to, a potential risk for mortality. The season that's the classic in North America typically is December through April. Sometimes it extends beyond that. Sometimes it doesn't. And the mortality is greatest in most years over the age of 65, with the exception we talked about in 1918, the mortality rate was surprisingly high for healthy young adults. If a patient comes to your practice, you're trying to differentiate influenza from the common cold. Here's a table or chart that kind of looks at sort of variation. Influenza, the onset is very sudden. Typically, you have a relatively high fever. They can have a dry cough, but the issues you'll see is often myalgia is pretty significant and severe, and the degree of weakness and tiredness and extreme exhaustion is sort of dramatic. It's, in a sense, it's often a very much more dramatic presentation severity than the common cold would be. I think our role as clinicians is to look at strongly encouraging vaccines for everyone. If the patient has been vaccinated but poses a very high risk for a current influenza outbreak, or the outbreak that is there is a strain different from what the vaccine covered, then patients may be a candidate for influenza prevention. The older agents, amantadine and rimantadine, are largely abandoned. I don't see these used anymore for influenza prophylaxis or treatment. They're only effective for a subset of strains when it's an outbreak of an influenza type A strain. They also have to be renally dose adjusted. There's central nervous system and confusion with it. So it's an agent we don't often see used. We would consider perhaps influenza treatment if a patient has severe symptoms and we catch it early or high risk for complications. But as we just alluded to, amantadine or rimantadine pretty infrequently used because it's only effective against the influenza type A strains and has a lot of confusion, agitation associated with its use. If an influenza acute treatment is used, it pretty much is limited to Tamiflu or oseltamivir. And this is an inhibitor of a neuraminidase, and it usually was only effective when you start therapy within 48 hours of the initial outbreak or symptoms of influenza. The sooner the better. What we're doing here is we're preventing viral influenza replication and hopefully reducing viral shedding so that patient will have less risk for transmission. What you'll often find is that a patient in flu season who presents with the flu, you're encouraging patients not to come into the office and transmit their influenza in the waiting room to everyone else. Instead, what you're really looking for is to have them hopefully call the office and try to sort of make that assessment based on their presentation and what you know for community patterns for influenza. And usually we'll look at an influenza nasal swab as well as part of that. But in any event, when you're looking at starting Tamiflu, the typical dose for normal renal function is 75 milligrams oral twice a day for 5 days. And if renal function is reduced, a single once-a-day dose. There's also a 30 milligram dose that can be used in some subset of patients in pediatrics as well. There is an IV formulation of a neuraminidase inhibitor, Rapivab, which was available from the 2015 season on. But I'll tell you, in our clinical practice, I've not seen it used, and I think its cost is a little cost prohibitive. Most patients who have influenza can take oral, and this would be somebody who wouldn't be a candidate for oral therapy. These agents can also be used in lower doses prophylactically for influenza when there's an outbreak. And I think the only time I have ever seen prophylactic use of one of these agents is in, for example, a long-term care setting or nursing home where the strain that is running through the nursing home is a strain different from what the vaccine covered, and or you've got a very frail population where you might consider using the lower dose for prophylaxis, the once-a-day dose. And that's typically only going to be Tamiflu or oseltamivir if it's used at all. A couple of years ago, the World Health Organization actually poo-pooed the use of Tamiflu at all. Their recommendation was that the evidence that demonstrated benefit that originally got Tamiflu on the market is somewhat suspect in that the data doesn't show a dramatic benefit. Uh, but that said, I will tell you that our experience, at least my experience in the Northeast, is that despite the fact that the World Health Organization has sort of poo-pooed the benefit of Tamiflu, we see clinicians, at least in this region, in the Northeast, in this 2018-19 influenza season, consider using Tamiflu for patients who've been exposed, or more commonly, who have actually a nasal swab positive for influenza. The rest of this presentation, there are a number of slides revolve around the management of HIV, both its prevention and its treatment. And I have to share with you that my experience, because of where I work, I'm a hospital pharmacist in an ICU and a med-surg unit. We see patients coming in on HIV therapies, but I don't work in a practice or an infectious disease service or primary care practice where we're doing a lot of HIV drug management or PrEP therapy. And so I'll go through this based on the national guidelines and the updated national guidelines as of early 2019. But I also defer to my colleagues in infectious disease to share their expertise, particularly if they work with HIV management or HIV prevention. So as a quick summary of HIV, really the causative pathogen for AIDS, basically HIV affecting CD4 T lymphocytes, which are become vulnerable and ultimately risk for opportunistic infections. And for those of us who sort of were in clinical practice at the dawn of the AIDS epidemic in the early 1980s, it was a very fearful and challenging time for clinicians. And our treatment options were pretty limited at that time. And what we found was the first agent was zidovudine, was available by the late 1980s. It wasn't really until the 1990s, or 15 years into the epidemic, that we had other modalities and recognized the importance of combination therapy with HIV and trial and error for therapies that would be tolerated by patients long term and had significant viral suppression. And so we look at some of those modalities and look at the newer treatments that we have in this day and age have rendered HIV not necessarily a death sentence anymore, but more of a chronic disease management. And so we think about folks who have HIV, certainly want to prevent it when we can, via behavioral approaches, if it's sexually transmitted or IV drug abuse transmitted, do what we can to protect patients who might be at risk for them, also using drug therapy, particularly PrEP and post-exposure prophylaxis as well. But if a patient is HIV positive, then we're also going to get an aggressive management of that condition. So I'm going to defer to our colleagues in infectious disease who also will share in their clinical medicine blocks about our process of diagnosing HIV. But we're going to look at both HIV tests themselves, maybe a HIV nucleic acid amplification test, but we're also going to test for viral loads. And we're going to use also a CD4 counts to help assess that as well. And so to really stage where a patient is who is HIV positive, you really want to know, first of all, are they HIV positive? And then secondly, what is their viral load? And thirdly, what's their CD4 count? So all of those are going to be important for us in the assessment of first diagnosing it and then assessing the status of where that patient is. The viral load testing, routinely now done. It's done throughout the therapy, the course of therapy, and the frequency of how often they're done depends on where the staging of the patients are in their therapy. And we also find that the viral load recommendations and the specific test recommendations periodically change. Recommendations change from the NIH or the CDC recommendations, so I encourage you to look at the latest guidelines there. As we alluded to, we're going to look at a CD4 count as a measure of immune function. In this day and age, it's pretty infrequent that we have patients now who have a CD4 count less than 500. But early in the first 15 years, 20 years of HIV, we we had lots of patients whose CD4 counts continued to dwindle down no matter what we did, and they started to present with opportunistic infections, particularly when the CD4 count started to get below 200 and then below 100 and then below 50. And that's basically the big fatality with HIV, particularly early in the course of the epidemic, is related to these opportunistic infections. For most of these now, we find that these antiretroviral therapy combinations really mean that the opportunistic infections are, I won't say unheard of, but they're very uncommon now compared to what they were earlier in the epidemic. There are some case definitions for HIV that, to my understanding, was last revised in 2014. But keep in mind that most folks who have HIV now don't have really advanced AIDS, but we do look at CD4 count in combination with other factors in assessing a patient's HIV status. And thankfully, again, because we have such better antiretroviral therapies these days, AIDS itself, the advanced progression of HIV that goes uncontrolled and leads to low CD4 counts, people with these opportunistic infections, these complications, based on their immune status, really would be considerations for getting the definition of AIDS. HIV progression we typically look at. It's the primary HIV infection that ultimately will progress to progression of HIV over time. We look at the viral product of virons, the viral particles that are produced every day. And our goal is going to be with therapy is to make viral replication halt, to stop it. And so we are going to seek an undetectable or a viral load of 0 in a patient. So that's going to be a critical issue for us. The role of immunizations, we don't have a HIV immunization at this point. I think there's been a lot of work on the potential for that over the last couple of decades, but nothing really that I'm aware of that's on the horizon there. But we are going to make sure that a patient who is HIV positive has adequate immunization, particularly influenza, pneumococcal, Hep A, Hep B, and then anything else that they fall in the category for. We're going to avoid live vaccines if their CD4 count is less than 200. But thankfully, again, most patients with HIV, if they're managed on antiretroviral therapy, won't see their CD4 counts go much below 500. So we're really hopeful there. Okay, in this next block of slides, and there will be a number of them, we're going to look at the agents that are used for the prevention or treatment of HIV. And a subset of slides will have a key on them. And when you see a key, those are the agents that are generally considered first-line therapy for treating HIV, or the therapies that are used most often in pre-exposure prophylaxis or post-exposure prophylaxis. And to my mind, as a clinician, particularly with your first real look at the HIV drugs, those are the agents you should look at. And in fact, I may talk about, you might see a key only on the combination drug product that's on the market. But the individual, we'll talk about each of the individual drugs very briefly. So the mechanisms of the anti-HIV drugs include primarily the two groups we focus on and where the keys are here are the nucleoside and non-nucleoside reverse transcriptase inhibitors. And that's about 9 o'clock on this slide. And those really work by stopping the viral replication via the way that reverse transcriptase works in viral replication. They're highly effective and are typically used in combination, often these days, with an integrase inhibitor, which is about 1 o'clock on this slide, blocking HIV from being integrated into the cell's DNA. And so a combination of a nucleoside or non-nucleoside reverse transcriptase inhibitor in combination with an integrase inhibitor, generally that really seems to be the magic combination of HIV therapies that has rendered our ability to really halt the replication of HIV and get to a viral load in most patients of undetectable. Some of the other therapies that are occasionally used include the entry inhibitors at about 11 o'clock here. Those agents, both the blocking T20 and the CCR5 inhibitors, are much less frequently used. Those are really second-line agents, usually in the realm of infectious disease services. And also the protease inhibitors. And the protease inhibitors were popular in the 1990s because they were only the next generation of agents to come after some of the nucleoside reverse transcriptase inhibitors were coming out. And they were hopeful. The problem with the protease inhibitors is that they're really second line because they cause a lot of metabolic changes in patients. They cause lipid abnormalities. They increase the risk for glycemic control problems. They cause weight gain. They cause cardiovascular risk enhancement in some patients. And so the protease inhibitors, they can be effective in combination for stopping HIV, but they're not first line anymore because of these metabolic problems. So let's go through some of the agents here and highlight some key issues with them, but I'm going to try to go through many of these more quickly. There are a number of tables that are going to now go through each of the classes of drugs, and they're each set in alphabetical order individually by class in the group. And that doesn't necessarily mean they're preferred if they show up sooner or later. It's just alphabetical order. So here's the first of the nucleoside reverse transcriptase inhibitors, abacavir. And abacavir is considered a first-line agent for some patients. The big issue with abacavir is that abacavir has a high risk for hypersensitivity. And so we really do need to carefully monitor patients and evaluate whether or not they're genetically predisposed to this hypersensitivity reaction by doing genetic testing in advance. So we'll talk a little bit more about that in a bit. But abacavir is a first-line agent for patients with HIV once you've ruled out or assessed what their genetic risk is for this hypersensitivity. Emtricitabine, though, is a moderately frequently used or included agent in a triple or double combination regimens. And so you'll see it's sometimes used as a non-reverse transcriptase inhibitor, reverse transcriptase inhibitor, as one of the common agents you'll see used. Lamivudine, also another NRTI, occasionally used in one of the combination regimens. We'll see not as common as some of the others, but you will still see it used. And then among the more common of the reverse transcriptase inhibitors is one of the two variants of tenofovir. There are two formulations of tenofovir. This one of TAF is included in a couple of the more common regimens or agents that you'll see on the market for tenofovir and pretty well tolerated in most patients. The other formulation of tenofovir also listed here is probably the one you'll see most often is Truvada in combination, very commonly used agent as a first-line agent and also used in PrEP and sometimes post-exposure prophylaxis as well. On to the non-nucleoside reverse transcriptase inhibitors, an agent not commonly used, doravirine. And in practice, I've never seen this agent used, but it's one that is still marketed and available as a sort of a second-line agent in a select group of patients. Another NNRT that was commonly used a decade ago or so, not as commonly used now, is efavirenz. Another NNRTI, Antivirals. I have no experience with this agent. I've not seen this one used, but it's a possibility. Nevirapine, an older agent again, was commonly used a decade and a half ago, not as common in the current recommended regimens. Finally, in this group, rilpivirine, another agent that is an NNRTI, but I have very limited experience with this agent, and it's certainly not a first-line agent in most cases. The next group are the protease inhibitors, and the protease inhibitors really because of all the metabolic complications associated with them, are really second-line agents now, but they are available, and there are a number of them on the market. They also have a lot of drug interactions, cytochrome P450 drug interactions that you need to sort of pay close attention to. They're harder drugs to manage. So ATV being one of them. DRI, another PPI, again, metabolic complications, drug interactions make these agents more difficult. The last couple of agents, protease inhibitors, are combination products. Ritonavir in combination with lopinavir is an older agent, again, not used all that often, and a lot of drug interactions and metabolic problems with it. And ritonavir, similar, same story here. The integrase inhibitors, or the integrase strand transfer inhibitors, a more precise term, there are a number of them, and probably the one you'll see used probably more than any of the others is DTG. And we see this used, dolutegravir is used probably more commonly than many of the others. We see it combination in a number of combination products. EVG, less common as an integrase inhibitor. It's a second-line agent, but it's available. The other a couple of integrase inhibitors that are in part of the more common combination products include BIC, and finally RAL, raltegravir, is also one of the more common additional agents in some of the combination products. The remaining agents we have listed here are not commonly used. They're second line. One of the fusion inhibitors that affect and fludavine, which affect cell entry into the cell. And so this is really a second line injectable agent. That is a consideration, but not first line. We also have a CCR5 antagonist that also affects entry into the cell. That's MCV. Again, not first line. We also have a post-attachment inhibitor for CD4, a monoclonal antibody that, again, has a fairly limited role of where it fits in practice. I have not seen most of these second-line agents in patients I see in the hospital. So in summary, that's really your toolbox in HIV. Next, let's go through some of the recommendations that the NIH has made for guidelines as far as what to do. And we're going to focus on adults and adolescents with HIV and look at some of the more higher level recommendations. So typically, we are looking in this day and age, and the last time these recommendations were updated in a major way was late in 2017. So expect some of these are going to evolve over time and change periodically. Every year, a couple of years, we see sometimes major, sometimes minor changes in recommendations. But typically, it's been pretty routine now for the last almost decade to look at treating all patients with HIV. Doesn't matter what the CD4 count is, we treat everybody. And the reason is because the agents are better tolerated now, and if you can get viral replication down to zero, then get their viral load down to zero, then it becomes really a chronic management disease, and we don't see a deterioration of immune function. So that's pretty standard. The other issue is that you really need to make sure that you're optimizing a patient's success. And that means that we don't really start therapy unless we know they're going to adhere to therapy. We're going to be concerned about patients who may only intermittently take their antiretroviral therapy, because what's going to happen is they will pose a risk for viral escape, that for the periods of time they don't take their antiretroviral exactly as it's ordered. Then you have the risk for viral escape, and viral loads go back up. If you have a mutation on one of those viruses, you could then end up with a resistant strain of HIV, for which you then have to rechange your entire cocktail. So rule of thumb is we start antiretroviral therapy in a patient who's going to adhere to therapy. We do everything we can to make them or help them adhere to therapy. And the regimens we have now is often a single pill or maybe 2 pills once a day, much easier. Early in Earlier in the epidemic, in the 1990s and early 2000s, patients had multiple medicines they had to take different times a day. Multiple times a day, they had this pill burden. It was terrible, and they were just exhausted just from trying to make sure they didn't miss a dose of their medicine. It was cumbersome and not well tolerated. That's not the case now. Everybody who is therapy naive patient, we're going to look at assessing their viral load and also assessing genotypically testing to look at potentials for resistance. We're going to also pay attention particularly to patients who are pregnant. And there's a lot of debate and ongoing evaluation of the risk-benefit of some of these regimens in pregnancy. And in fact, as of early April 2019, some of these agents are undergoing reevaluation. We're expecting new guidance shortly on what the role of some of these agents' safety would be, particularly with the integrase inhibitors, in a patient who could be pregnant or women of childbearing age. And so that may change some recommendations in short order for women of childbearing age or women who are pregnant. But we're going to look at that testing. I'm going to defer to your clinical medicine folks to also kind of support some of the decision making or some of the thought process in drug-resistant testing. Well, also, there's probably more of a role even for patients who have had experienced therapy for drug resistance testing. That's going to be particularly true for a patient, for example, who's been on an antiretroviral regimen for a while, and all of a sudden their viral load, we initially got it down to undetectable, but it popped back up again. If it popped up again and they've been adherent to therapy, then by default they're probably resistant. We need to get resistance testing for their HIV strains that they're currently now having and make sure our new regimen really covers that more resistant strain. And then also more guidance as far as resistance that's more specific in how we assess that. The initial combination regimens for antiretroviral naive patients typically are going to look at a combination therapy. Typically what you're going to find is that patients are going to be on 2 nucleoside reverse transcriptase inhibitors plus most commonly an integrase strand transfer inhibitor. They could use something other than integrase inhibitor, but that is not a common scenario in the first-line regimens at least. And then the other issue is the pregnancy testing, and keep an eye out for the role of particularly some of the integrase inhibitors in pregnancy risk that's evolving, and sort of we'll get a better sense of that. There's also recommendations for which agent or combinations there are here, and they're sort of listed which are the agents. I encourage you to go back and look at the table, but all of the agents we sort of highlighted with keys as the combination products are listed here. And you'll see that most patients will do well with a combination product that includes an integrase inhibitor and 2 non-nucleoside reverse transcriptase inhibitors. The one we worry about most is the second one on this list with the bacavir. In those patients, we do worry about hypersensitivity reactions, and so you have to make sure they are HLA-B 5701 negative before you start that because of the hypersensitivity risk. Finally, the last bullet here talks about folks who are getting one or more of the integrase inhibitors and whether or not that poses a potential risk in women of childbearing age, particularly for neural tube defects. And so that's evolving. Expect by mid-2019, there's going to be more specific recommendations about that. Other recommendations listed, there are many of them, and I'll have you sort of go through some of the slides here, but just keep an eye on what the recommendations are, on which therapies they start, and how we do encourage patients to have this simpler regimen. We want to pay attention to their viral load. We want to make sure they don't have toxic reactions. We're sensitive to their pill burden and burnout. We want to make sure they adhere to therapy. There are a lot of drug interactions with the treatments for HIV. If you have HIV plus tuberculosis, then we're particularly concerned about the interaction with some of the TB drugs with HIV. And so we really have to particularly pay attention there. And so lots of things to sort of consider, and some of the tables that we'll include later in this presentation will go through some of those considerations that clinicians will have. Now, as a clinician, you may not be the person to start them on their antiretroviral therapy when they're HIV positive, but you are probably, particularly if you're in primary care, going to be much more likely being in a position to assess a patient who comes to you with risk factors for HIV and evaluating whether or not they're a candidate for pre-exposure prophylaxis. You could also be in a situation where you've had someone who's had a recent exposure to HIV and you want to look at their post-exposure prophylaxis requirements. So encouraging you to go to the CDC's website and do a sort of a little more review of what's available for pre-exposure prophylaxis and post-exposure prophylaxis. And the data for that has evolved. It's become much more mainstream. And the approach I'm going to take is exactly right from the CDC's website. And they have sort of a 10 or 11 frequently asked questions for pre-exposure and post-exposure prophylaxis that I think gets to the heart of the issues with each of these. So pre-exposure prophylaxis is a regimen that's available for higher risk patients for higher risk with HIV. Pre-exposure prophylaxis became more commonplace and was really the pre-exposure HIV. They have a nice, on the CDC's website, a guide for healthcare providers of frequently asked questions. Let's go through all of those quickly. I won't try to belabor it because you can read this more slowly on your own. Keep in mind that pre-exposure prophylaxis, or PrEP, is short for the antiretroviral medication that's going to be used on a patient who's HIV negative, who's at high risk for becoming higher risk for becoming HIV positive. And the combination product is really tenofovir, disoproxil fumarate, and emtricitabine. And this combination as a fixed dose, the brand is Truvada, is the standard PrEP dose that's used for almost everybody who's on PrEP. This is now where this may change over time is if a patient is in a population area or their risk exposure to drug-resistant HIV might be greater. Imagine over time this recommendation for Truvada may change or evolve to something else. So keep an eye on this, but that's currently the recommendation that's made. The guidelines are found, the more specific guidelines, you go to the CDC's website as it's listed here, and encourage you, if you're a clinician who does a lot of that, I think you want to really pay attention to that and be aware of that. Who can prescribe PrEP? Anybody who's a licensed prescriber can. And in fact, because the demand for PrEP is outstretching the available resources in infectious disease or with HIV specialists, we're seeing more and more primary care providers looking at starting or being involved in starting PrEP. So this is becoming much more of a first-line primary care role in the fight against HIV. I think of all the questions I've seen with PrEP, this one is one of the more important ones to get a hold of. Who are the patients who are candidates for PrEP from the CDC? Well, keep in mind that the best thing for a patient to avoid HIV is to avoid whatever the risk factors are for developing HIV. So avoid the exposure to the extent they can. So what's really critical is to look at those folks who are at higher risk for HIV, and is there something before you go to PrEP that could render their risk much lower? So, for example, the highest requests you're probably going to have as a practitioner are from men having sex with men. And in this population, there is a lot of awareness for PrEP, and they may come to you as part of their, either that is their request or They're going to look at a specific request for it or part of an annual physical or something and ask that question. So who's a candidate? First of all, men having sex with men, if they're at least 35 kilograms, they don't have HIV, they test negative for HIV, and they've had multiple sex partners in the prior 6 months, and or they're in a non-monogamous relationship with someone who is tested HIV positive. All of those plus what would indicate that they're higher risk for HIV despite all of those is if they don't use condoms, particularly if they've had anal sex in the past 6 months, or if they've had any sexually transmitted infection, which by default suggests that they may have not used appropriate barrier and protection. And so that's indicative of perhaps a higher risk for HIV. So those are really who are the candidates for HIV and higher risk and the candidates for PrEP. Similar for heterosexual women and men, the category sort of mimics a lot of that, and also for IV drug abuse are pretty similar recommendations, but also if they've had the higher risks with injectable drugs of not using their own works or their own injectable products, if they've shared equipment in the last 6 months, or they're at high risk from the prior variables of men who have sex with men or heterosexual men and women risk groups as well. I think the patients you're going to see most often requesting PrEP are men who have sex with men, or perhaps men or women who inject drugs and pose a risk for sharing needleworks. So Truvada is the common agent that's used for PrEP. It's dosed once a day orally, and you have to really evaluate before you look at the patient who's a candidate for PrEP. You want to make sure they're going to adhere to therapy, that there's, you may need a couple of visits to confirm, well, before I prescribe PrEP for you, I need to know that you're going to really adhere to therapy and can be consistent with it. You can also look at patients who are going to communicate well with you if they have any side effects or toxicity. They're going to talk to you if there's potential that the patient could become pregnant, if that's an issue for the patient in front of you. Those are all going to be sort of important considerations. The evidence for PrEP is pretty good. For depending on the population that's listed here, anywhere from 70 to 92% effectiveness in preventing transmission. So those important considerations for patients. The things to think about, though, with PrEP is that you still want to strongly encourage condom use with sex and using your own needles if it's IV drug abuse. That the PrEP may also reduce the risk for HIV, but it doesn't eliminate it. So the issue is here the effectiveness of preventing HIV is very good, but it's not 100%. So you need to share that as part of the education. The other issue is that the patient who doesn't use barrier protection for sex or doesn't use their own needles and IV drug abuse is also at all of the risks for any of the other sexually transmitted infections. And so as such, you really need to encourage that the barrier protection with sex or the own needles are still critically important on top of giving issues for PrEP. And the other issue is that there is a subset of patients who may kind of think, oh, I'm on PrEP, so I don't have to use my own needleworks. I can share them now because I'm on PrEP. Or I can have sex without using a condom now because I'm on PrEP. You need to sort of convey, A, it's not 100% safety for doing that, and B, they are going to be at higher risk for the other things that otherwise protective behavior would have protected them against. So that's critical sharing information as part of that discussion. Adherence to PrEP, critical. You don't adhere to PrEP, you risk all the risks for having a problem with both exposure to HIV and then that also posing an increased risk for a problem with resistance developing as well. Generally, the data for PrEP with the standard PrEP regimen has not been problematic. I think we are worried most about the issue for women of childbearing age, pregnancy, and breastfeeding. It's probably considered safer, and the risk compared to not PrEP, depending on what the risks for HIV are. But just keep in mind that that's an evolving question for any drug with pregnancy and the pregnancy risk. So who shouldn't get PrEP? If you're HIV positive, you treat it as an HIV positive patient. You might be on Truvada based on a first-line agent for that, but you're probably going to be on a triple regimen therapy. And also, for folks with renal insufficiency, with a creatinine clearance less than 60 mils per minute, they're not candidates typically for PrEP therapy either. For folks who are on PrEP, you need baseline HIV testing, and then you get that done periodically during at regular visits as you're reevaluating their ongoing use for PrEP therapy. So baseline assessments, you're going to send blood for HIV antibody antigen status, and if they're negative, you can start PrEP. You'll retest the antibody in a month, and then if they're positive, then you're going to sort of defer that decision and go from there. And then in circumstances where it's appropriate, you may look at a viral load if they're antibody positive. Assessing somebody's renal function periodically makes sense while you're on PrEP. You may look at their liver serology as well, particularly if they're Hep B or Hep C, and particularly for men having sex with men, you want to make sure that they've had their Hep B, Hep C vaccination, maybe their Hep A vaccination, and you want to look at what other vaccines that patient should be up to date to. Also, there's like an algorithm here I encourage you to look at based on their blood test and then how they go for PrEP, yes or no, and sort of what you do. It kind of outlines what we more or less just discussed. What are other things for folks who are on PrEP? Well, you need to look at the ongoing support for that patient. They'll need regular HIV testing. They need to conform to adherence to therapy. You need to encourage continuing safer sexual behaviors. So the kind of things you're going to look at in monitoring, you're going to assess at every visit, how they're doing overall, how their adherence is going. You're going to do HIV testing every 3 months, and then anytime there's a question of active infection. And then you're going to screen for sexually transmitted infections when they're appropriate, as is listed in this table. You're going to look at their renal function initially at 3 months and then every twice a year. You're going to also look for pregnancy testing every 3 months for a woman of childbearing age. Can PrEP be covered by insurance? Many insurance plans do cover it. That varies based on a case-by-case basis. And how could a patient acquire HIV when they're on PrEP? They could. There have been situations where that's happened. So you want to sort of be aware that that can happen. You want to also inventory the kind of at-risk behaviors that could have posed a risk while a patient was on PrEP. Also, were they adherent to their therapy? And then what's the plan or recommendations for treating HIV in a patient who one patient has HIV and one patient doesn't? Do you just treat the HIV positive partner as you normally would, or just the negative partner, or both? And oftentimes patients might be benefiting that both patients get considered treatment. So they sort of outline some of that recommendation here. So that in a nutshell is pre-exposure prophylaxis. In a minute, we'll go on to the post-exposure prophylaxis regimens. Okay, with HIV coming more into the home stretch here is the post-exposure prophylaxis guideline. Post-exposure prophylaxis really for folks who are either have an occupational or a non-occupational exposure to HIV. And we consider exposure a medical emergency because HIV infections can develop really quickly after exposure. And so we really want to do our best to get that person in right away. Most hospital protocols, for example, or health system protocols, you get a needle stick, you talk to your whoever your boss is immediately, you get relieved from your duty, you go to either employee health or the emergency department right away, and like immediately, they do the appropriate serology blood testing, and the goal is for you to start your post-exposure prophylaxis within an hour of your needle stick. We really want to do that aggressively. If you go beyond, the longer you go beyond the exposure, the less effective the post-exposure prophylaxis will work. And once you're beyond the window of 72 hours, there's probably not much benefit at all for doing post-exposure prophylaxis. The CDC has a set of guidelines. They're posted. I encourage you to sort of look at the more specific guidelines, but these sort of frequently asked question slides kind of go through the crux of the main issues. And I'm not going to read through a whole slide, but you get the sense of what we're looking at. So the kind of exposures, you want to assess what the risk of that exposure was. So was it a sexual exposure? Was it a vaginal, a rectum? Was it mucous membrane? Was it non-intact skin? Was it perforated skin? Was it needle stick? What is sort of the risk for that? And all of those are considered, as we load, are considered higher risk. The other issue is to establish what was the HIV status of the patient or the patient for whom that blood or secretion was identified from. And so that's important to sort of know that. Here's sort of a strategy or an algorithm to look at assessing the windows of time of when you're going to do which intervention. Any licensed prescriber can give post-exposure prophylaxis regimen. The regimens are, the preferred one is tenofovir plus emtricitabine, plus adding additional agents on top of that. So it's really a 3-drug regimen as our preferred regimen. There is also a alternative regimen that's also listed here. And usually in most healthcare settings, and you'll see over time that the CDC may recommend a different post-exposure recommendation, but you'll see that most healthcare settings have these ready to go, so that the emergency department or the employee health service in that organization has these as post-exposure kits ready to go. You go through the appropriate workup and you get the tablets initially to start your first therapy and a prescription to complete the course, the 28 course of therapy. But you get your first 3 days worth right in the emergency room. You take your first dose in the presence of the provider who's treating you. Basically, the recommendation for the therapies, abacavir, typically not considered a PrEP regimen because you don't get the turnaround time available for clearing the hypersensitivity risk testing in time. The evidence for PrEP is reasonable. Some of the studies that looked at appropriate use, not the best of studies, demonstrated an 81% reduction in HIV infection, and so that's pretty good data. The sooner you start, though, the more effective it is, and so we're going to really be careful about the nature of that. PrEP is, for most patients, well tolerated and safe. It's a little bit more than your pre-exposure regimens because there are 3 to 4 drug regimens that could be used. So there's sort of more involvement, but they're generally well tolerated. The biggest side effects are GI and maybe a little fatigue. So who does not get post-exposure prophylaxis? So if you know that the exposure was in a patient who did not have HIV, then they're not a candidate for post-exposure. For patients where it's more than 72 hours, and it should only be an option for infrequent exposures. This is not sort of your plan B for every time somebody keeps coming to the emergency room. They should be on pre-exposure prophylaxis if they keep coming in after a question of exposures. Other issues because of pregnancy, there's a lot of debate about where that stands, and renal dysfunction. So you want to be, in that case, usually you're talking, or the clinician in the emergency room might be talking with someone from infectious disease or someone else about what's the appropriate next step for us in this patient and assessing their risk for post-exposure prophylaxis. But you want to do that without too much delay. Baseline requirements are we're going to get a rapid HIV test before we start, a pregnancy test, LFTs, you're going to get a BUN and a creatinine, you're going to screen for sexually transmitted infections if it's related to a sexual encounter, you're going to get Hep B and Hep C testing, antibody testing as well. So here's sort of a table of most of that additional supportive data and what testing you're going to get and when you're going to get them and how you're going to get them, sort of listed in a nice table format. The table also has a number of abbreviations. Here are the abbreviations to that table. I would think that in most circumstances, post-exposure prophylaxis is covered by almost all insurers. I frankly would be quite surprised if it were not, and there are assistance programs for patients as well. This table is always changing. This is about 8 months old ago since I'm recording this, but it lists the standard typical costs for some of the more common HIV regimens. And these really vary based on, parts of the country. Drug pricing is like airline pricing. They're very hard to sort of predict. But some of these regimens can be pretty expensive to continue, and a monthly cost, can be in the range of thousands or thousands of dollars if you're looking at how you manage therapy and what's covered by insurance or what's not covered by insurance. There are also resources for paying for treatments, and I encourage you to look at the hiv.gov website that offer that, particularly if this is a population you're working with that is in need of financial support. The last few sets of slides really are less commonplace now than they were 20 years ago. These are the opportunistic infections we worry about in advanced HIV or immunocompromised status. But if we're using the antiretroviral therapy according to the latest guidelines, it's pretty common to see that patients will maintain their CD4 above 500, and these opportunistic infections will not happen. But keep in mind the kind of things that you worry about when CD4 counts start to get below 300. So this is a chart that's been, a similar chart we've used for years and years when we think about CD4 counts as it relates to opportunistic infections. And you see the risk for lymphomas, sarcomas, TB risk goes up when you get below 200, thrush, candidiasis, herpes infections, all the way down to Mycobacterium avium complex infections or cytomegalovirus infections, cryptococcal meningitis, other kind of problems can happen as well. So thankfully, this is a much more rare circumstance now than it was a couple of decades ago. So in clinical practice, we're fortunate that for the very few patients which you see who do have an opportunistic infection, here's some guidelines and standards. PCP pneumonia, we still use Trimsulf as our standard regimen, but pentamidine, a few other agents, atovaquone also, are agents that could be used. And PCP pneumonia or pneumocystis pneumonia is one of the few infectious states where we routinely use corticosteroids because of the acute inflammatory reaction that pneumocystis pneumonia actually presents with. For patients who have, unfortunately, cryptococcal meningitis, those folks will require aggressive management with amphotericin B, which we typically going to limit to, in this day and age, a tertiary care facility Usually we're going to use one of the newer, meaning last 20 years newer, versions of amphotericin B instead of the older formulations, and then switch them to an azole antifungal if that's then appropriate. For cytomegalovirus, again, we talked about that earlier in this presentation. Ganciclovir and then valganciclovir are pretty much going to be utilized. There are alternatives with either foscarnet or cidofovir. And then for Mycobacterium avium complex, typically a macrolide, usually the one I've seen is clarithromycin plus ethambutol, sometimes rifabutin or one of the other agents. You've just got to be a little careful with some drug interactions with the HIV antiretroviral regimens as well, particularly when you add either a macrolide or particularly rifabutin, one of the rifampin derivatives. Finally, toxoplasmosis, thankfully, again, quite rare. And usually in these cases, you're going to find you're getting input from the ID service. Okay, there's a tremendous amount of information here. I'm hoping you're able to digest and see the big picture and the big themes associated with antiviral therapy.
Let's spend a few minutes talking about COVID and its management. It has evolved certainly since COVID was first identified in late 2019, and we began with therapeutic options in early 2020. Things have evolved. Early on, we were managing patients who had COVID pre-vaccine availability. We managed folks the best we knew, and some of that data included things that we look back on now and say, well, gee, there really wasn't data for that, and we don't do that anymore. Particularly including things like hydroxychloroquine were pretty commonly used in the first few months to half a year or so when we were trying to manage COVID pandemic in acute care particularly. Let's look here at some of the big places you'd want to look and some of the big themes with COVID-19 therapeutics. One is the vaccine, and you should always go to the CDC's website for the latest update in the recommendations for COVID vaccine. As of September 2022, there is now a bivalent vaccine booster available and for patients who are eligible, which is usually most patients over the age of 12, or 18, depending if you're talking about the Pfizer booster or the Moderna booster. A little bit more on that in the vaccine section. But I encourage you also, when you're questioning or wondering where is a good place to get the latest information about COVID therapeutics, it's the Center for Disease Control website, cdc.gov. As you look through, they also have a nice link to updates and guidelines, and these summarize guidelines for you of whatever sort of the latest guidelines are. These guidelines were accessed on September 10th, 2022, but you'd expect that you'd see, so here as of that time, they told you the latest update was in August of 2022, and they tell you, and they kind of time when the new updates come through, so you'll know if you're dealing with current information, and you'll know whether or not, hey, I already knew this because I had looked at this at that time. That's helpful. What some of the key features you'll find when you look at these are the role of monoclonal antibodies, which there is a role, but it's a somewhat limited role of when we use monoclonal antibodies in COVID. And a lot has to do with, as the variants have changed in COVID, we see that the monoclonal antibodies that initially came to market for COVID were for variants and targets on COVID that were, or spike proteins or something else that's no longer a common modality now. It's not effective because the antibody is not directed against something that's in the current strain of COVID. There'll be special considerations for individuals who are immunocompromised. Those patients include severely immunocompromised patients, like folks who are on immunosuppressants for transplant medicine, patients who are undergoing chemotherapy. And then for some patients, more immunocompromised than others are, for example, chemotherapy patients who are being treated for B-cell lymphomas, where we give a drug called rituximab, which kind of wipes out their B cells that make antibodies. So those individuals particularly are going to be candidates for passive immunity with antibodies. And if they've got rituximab, they probably won't mount an immune response, an active immune response with the current vaccine for at least a year after their window of rituximab has stopped. So we'll talk more about that as the year goes on, but you need to think about if it's an immunocompromised patient, the public health measures of keeping patients away from crowds, using masks, social distancing, the standard public health measures we've used are recommended for everyone, but particularly those who are immunocompromised. And then the role for specific modalities that are maybe monoclonal antibodies, passive immunity for those individuals is helpful. They also update guidelines for children. You can look at those more specifically. They will give you other recommendations as time goes on for both non-hospitalized and hospitalized children and non-hospitalized and hospitalized adults. They will give recommendations also for preventing infection in specific cohorts, what the latest public health data is or is not. Additionally, they will talk about hospitalized patient and community patients who don't need to be hospitalized with guidelines. They also will sort of refer you to the treatment modalities, one of which we'll talk about in a minute, Paxlovid, for the outpatient management of folks who are at risk for severe complications with COVID. And a drug like Paxlovid has many, many drug interactions you need to be aware of. And so many times we have to stop therapy or interrupt therapy while patients are on that modality. This slide sort of refers to that, not a focus right now for you to memorize all of this, but to have an awareness of it so that when we go back and talk about these issues later on in pulmonary, you'll have a context to address them. One of the nice things that the summary slides give us in the CDC is a way to consider how to manage therapies in non-hospitalized adults with COVID and hospitalized adults. And they give you sort of updated charts, which get updated, sometimes weekly, sometimes every couple of months, depending on what changes have happened. But in the non-hospitalized patient and the hospitalized patients, we really pay a lot of attention in COVID about whether or not patients require supplemental oxygen or not. And if they don't, those are not as severely affected patients. Whereas if we have patients who have been recently discharged from the hospital, whether or not they have oxygen need or supplemental oxygen or not will sort of dictate the continuation of their in-hospital dexamethasone, for example, or their antiretroviral therapy. Okay, what you'll often find is that there is a role for folks who are high risk for using antiviral therapy early in the course of COVID. And one of the things you'll see here is Paxlovid is probably the standard therapy, or IV remdesivir is sometimes used if a patient doesn't have oral access, for example. And those, again, are pretty much limited to outpatient, particularly Paxlovid, limited to outpatients who have high risk for progressing to severe COVID. Those are folks usually who are immunocompromised or who have other comorbidities like heart disease, pulmonary disease, or are immunocompromised in any way, so or older. So important to kind of consider those factors, but more detail later in the year. And one of the last big areas in this chart go through the hospitalized management of patients with COVID, and this gets tweaked periodically as well. But the theme is generally that we see with COVID that patients, particularly who have a risk for developing COVID, significant outcomes with COVID, and particularly if they have some oxygen requirement, those patients are usually candidates for antiviral therapy. And in the hospital, the antiviral we currently use for COVID is remdesivir. It's usually given as either a 3 or a 5-day regimen for folks who usually have some significant risk associated with their COVID presentation or severe, often for folks who have some degree of oxygen requirement. And then we'll look at dexamethasone also. Dexamethasone is helpful, early to mid to later COVID because of the inflammatory response of COVID. So, as we kind of alluded to in principles of antimicrobials, there are certain cases where we actually want to use dexamethasone or prednisone therapy, even though it's a little bit immunocompromising or immunosuppressing, because the risk for the inflammatory reaction to certain infections is greater than the potential downside of modest immunosuppression with these agents. So COVID, particularly in more severe COVID, dexamethasone is pretty much a standard of care. Finally, there are also guidelines in pediatrics, and again, it depends on the age. The cutoff in most use both for vaccines and for antivirals in COVID relate to ages 12 and above. 12 to 17 are often, if significant high risk, are candidates for Paxlovid or remdesivir, and ages 12 to 18 are also candidates for some of the vaccine requirements vary based on age, 5 to 12, 12 to 17, 17 and above, or 18 and above. For those who are aged under the age of 12, there's not as much data for the safety and efficacy of drugs like Paxlovid or remdesivir, and so we're waiting for more data to come to bear. Okay, so as you look at all of these antivirals, there's a lot of detail in these slide sets. Just kind of have an appreciation for the kind of antivirals, the specific. Is it a DNA virus? If we're talking about a herpes virus, we could look at drugs like acyclovir, valacyclovir, famciclovir. If we are looking at CMV, cytomegalovirus, a specific set of antivirals we'll use in that case, which don't cover other viral infections very well. And then we have specific treatments for Hep B, really, which aren't great, Hep C, which are great, and HIV, which are great, but not curative. And lastly, the big issues we think of with influenza, COVID, other antivirals, they have sort of specific drugs with specific niches and guidelines, and COVID specifically is an evolving science. So hopefully this is helpful for you to sort of picture the role of antivirals and more specificity and reinforcement throughout the year.